Dr. Dokras, we'll begin with you. And we'll start with some very basic information for our listeners to lay out the background so that they get an idea of what we're discussing. So it'd be really great if you could talk about the basics of PCOS and why diagnosis is difficult, and probably touch upon the new international guidelines for PCOS diagnosis as well.
So good morning, Priya. Thank you so much for inviting us and organizing this podcast. So let me start with saying that PCOS is the commonest endocrine condition in young women, in reproductive age women, and about 6 to 8 or even up to 10% of women in this age group are known to have PCOS. So it's an important condition because it's so common. The international guidelines were published this year because we know that women with PCOS are very unhappy with their experience with the diagnosis of PCOS. There are studies that tell us that some women take 1 or 2 years before their diagnosis is confirmed. Sometimes they have seen 2, 3, 4 physicians before the diagnosis is confirmed. So it's a really good thing that now there will be uniform guidelines that are going to be used internationally. A number of medical societies have approved these guidelines. A number of international experts were involved in putting these guidelines together. And that's what all physicians as well as patients can now refer to as their diagnosis is made. So just briefly to give the background as to what is the diagnosis based on, the most common symptom that women with PCOS have is irregular periods. And so this is like patients will usually say to me they get 2 periods a year or 3 periods a year. But it can be mild. It can be up to 8 or 9 periods a year as well. The second criteria is signs of high male hormone levels. So they may complain of increased hair growth. And the hair growth is usually in the middle of the body, like the upper lip, the chin, in the middle of the chest, the inner thighs. It's those areas. It's not like the eyebrows or the underarm areas. And then the third criteria is if we were to do an ultrasound, these ovaries have a very typical appearance with lots of eggs or follicles within them. So having any 2 out of these 3 will qualify for the diagnosis of PCOS.
So 3 symptoms that you mentioned. Dr. Amaro, I'd like to bring you into the discussion now. Dr. Dokras just mentioned excess of hormones. So probably to dig a little more deeper, can you just explain to our listeners what is going on hormonally within the body if I have PCOS?
Hi, Priya. Thank you again for organizing, and thank you for inviting me to be part of this important discussion. I am an endocrinologist and happy to speak about the hormones. As Dr. Dokras already mentioned, one of the symptoms is resulting from excessive male hormone production by the ovaries. Overall, PCOS is a complex syndrome, so several things are happening simultaneously. And we sometimes don't even know what leads to what, but what we see is, first of all, we see excessive male hormone production, and they are produced by ovaries. Second thing that we see is signs of insulin resistance. So insulin is a hormone that is needed by many tissues and many organs, and it does slightly different things in different tissues. So different tissues may develop resistance to insulin, and that can cause different manifestations, different symptoms. For example, insulin resistance in the liver can result in accumulation of the fats in the liver and slightly higher blood sugar in the morning, because liver can be making that sugar overnight. A resistant liver can be making the sugar overnight. Ovaries can also be insulin resistant, and ovaries can be exposed to higher levels of insulin in insulin resistant individuals. So it is possible that from that they are slightly malfunctioning and begin producing excessive androgens. Androgens are male hormones. And that's why women may notice irregular periods and excessive hair growth. Insulin resistance is also associated with excessive weight. In fact, people who gain weight may develop insulin resistance. On the other hand, people who are born with predisposition to insulin resistance are more likely to gain weight. So that is why women with PCOS oftentimes have excess weight. And that's what we try to do in Penn Metabolic Medicine. We try to help with weight management, with non-surgical weight management. Another feature, another symptom of insulin resistance can potentially be diabetes or abnormalities in glucose metabolism, prediabetes or diabetes. And we also know that lowering the weight can improve some of the hormonal disturbances. Losing weight can improve insulin resistance and postpone the development of diabetes. And weight loss can also improve secretion of the hormones by the ovaries.
Mm-hmm. Yeah, interesting. Actually, when hormones play up like this, it's often like a massive assault on a woman's femininity. So, Dr. Allison, how do women cope up with this emotionally, and what are some of the common psychiatric issues that you've seen in women with PCOS?
Yes, thanks also for having me on, Priya, with my good colleagues, Dr. Dokras and Dr. Amaro. It often does take a team effort because of all of these symptoms that we're talking about. So on the psychology side, we often do see that women with PCOS can have a higher risk for depressive symptoms, anxiety symptoms, as well as eating disorder symptoms. We think this is likely related to several of the manifestations of PCOS that have just been discussed. So you can imagine that these hormonal differences from other women can influence mood swings, which may be a contributing factor to the depression and the anxiety. The increased insulin resistance, which is related to the increased weight. We know that weight gain can also influence mood and anxiety, as well as excess hair growth. So this is a tough symptom to have to deal with. It's visible as weight is, and we know that appearing different can really be at a detriment to one's self-esteem and create poor body image. And so those seem to be moderating factors for these increased symptoms of depression and anxiety that we see. And then finally, with the increased weight gain, sometimes it does seem more difficult to lose weight given the hormonal irregularities for women with PCOS. And with that, because it becomes so difficult, we think that women with PCOS may be more at risk for developing disordered eating types of behaviors, like they maybe engage in more extreme types of weight control behaviors like fasting or inappropriate compensatory behaviors. And so those are all things that we have to be mindful about and if significant enough, treat independently, in conjunction with the metabolic treatment of the disorder.
Thank you, Dr. Allison. At this point, I'll bring in Peggy. Peggy, as I was mentioning, was part of the COMET-PCOS study, and we'd like to hear from her. Peggy, how did you know that you had PCOS?
Hi there. Hey, yeah. Thanks for having me on the show. So I was actually first diagnosed by accident. I was rushed to the ER for presumed appendicitis, and they found golf ball-sized ovarian cysts instead. But because I was in my teenage years, they thought that perhaps it was a fluke, and there wasn't really a whole lot of research being done in my area at the time. So they did nothing. They didn't recommend birth control or anything. They just played a wait-and-see approach. But when I entered college, my symptoms actually got quite a bit worse. So I had some sudden onset acne, stubborn weight gain, even with diet and exercise. I wasn't getting my period, excessive mood swings with depressive features, and all of these things together prompted me to go to an endocrinologist and get formally re-diagnosed. And so some of the things that my endocrinologist did to try to find a diagnosis for me was, thyroid testing, a lot of glucose tolerance testing, and of course, testing my testosterone and female hormone levels.
Mm-hmm. So were you put on any medications for managing your symptoms?
So once a lot of the test results had come back, we found that my testosterone was consistently elevated and that there was no issue with my thyroid or really my blood glucose, but he had heard about Metformin. So I had tried Metformin for a few months in college with almost phenomenal success. It brought my periods back almost immediately. I lost 10 pounds within the first month or two of taking it. It really worked just phenomenal. But because I was in college at the time and I couldn't commit to taking it properly, especially with the presumed risks that sometimes exist on it, I switched to a third-generation birth control, like a generic of Yaz, for a year, which also seems to keep symptoms at bay, just in a different way.
Thank you, Peggy, so much for sharing that, because actually it kind of resonates with so many of our questions. Because we've been trying to get a feeling of exasperation from some of them. So Dr. Dokras, we had this question from the audience saying that I've just been diagnosed and I'm overwhelmed, and where do I begin? And we just heard Peggy say she was diagnosed accidentally. So can we talk a bit about what is the first step in diagnosis and treatment when we suspect that someone has PCOS? And would be great also if you could comment on some of the tests that are used for diagnosis and the first line of treatment.
Yeah, I think this is a very important question, Priya. And the diagnosis of PCOS is really not difficult. It can be done by your OBGYN, your internist, a family doctor, and of course endocrinologists, and then reproductive endocrinologists like myself. So if you think about the three criteria that we use to make the diagnosis, so if our patients talk about having irregular periods, like Peggy mentioned, she wasn't getting her periods, then we need to make sure that no other endocrine hormones are abnormal and they are not the reason for the irregular periods. So one of the tests that we do is a thyroid test to make sure that those hormones are normal. There's another hormone which is made by a gland in the brain. It's called prolactin, which can make periods irregular, so we check that. And then we check the female hormones that Peggy was referring to make sure it's not somebody who is like in premature menopause. So we are trying to exclude other reasons for the irregular periods. So it's a set of blood work that will give us the answers for the first criteria. Then the second criteria can be the excessive hair growth, less common acne beyond the teenage years, and then the least common is hair loss, sort of in that order. And then the blood test that we would do with that is the male hormone level, and the male hormone here is called testosterone. So your doctor might either do the total or the free testosterone level, and the free is the most sensitive one. So that's also just part of that same blood test. So one blood draw can give us the answer for the first and the second criteria. And then the third one is an ultrasound. And on the ultrasound, what we are looking for is a slightly bigger ovary, so we have cutoffs for that. And the ovarian volume gets measured, and then we count the number of follicles. So it's very unfortunate that about 80 years ago this syndrome was named as Polycystic ovary syndrome. So the impression is that there are a lot of cysts within the ovaries. but really it's tiny follicles. They are between 2, 3, 4 millimeters up to 9 millimeters in size. And that's what we are measuring, the number of these follicles. And it's really a part of a woman's ovarian reserve or their fertility. So the more number of follicles, that's good news. That's really not bad news. And that's one of the criteria for PCOS is increased number of follicles. And if a patient has 2 or more of these criteria, then they meet the diagnosis. So it's one blood test and one ultrasound currently can get us the diagnosis of PCOS.
So are there any specific challenges regarding the diagnosis based on the age of the patient, the adolescent, or probably the menopausal women?
Yeah, that's a very good question, Priya, because, PCOS looks different in different patients. It looks different based on age. So in a teenager and as you get older, it also looks different depending on where in the world you are and your ethnicity. It looks different based on your weight. So this is really an important question. So if we talk about in young girls and in teenagers, when you first start getting your periods, it's very common for periods to be irregular. And so we cannot use that first criteria of PCOS in a young teenager, especially in the first few years when they've just started getting their periods. The recommendations from the international guidelines are to wait at least 2 years or a little longer to see if the body resets and these periods get regular, and not to rush into making the diagnosis that early on. Even for the second criteria, it's hard in teenagers because acne is a common symptom, and it's not necessarily related to PCOS, but just related to going through puberty. A lot of teenagers will have acne, and so if they have that combination of irregular periods and acne, one should not rush into making the diagnosis of PCOS at that time. And I typically say to the young girls that I see, let's keep a menstrual calendar. Of course, we manage the acne or symptoms that they may have, but don't label them with the diagnosis of PCOS because they get very concerned, parents get concerned, and it is okay to wait a little bit before you can confirm the diagnosis in that age group. The other age group you asked me about is the women who are more like in their 40s or 50s getting towards menopause. And nowadays, given the increased awareness of PCOS, we do have a number of patients who will come in and say, I think I had PCOS when I was younger. I don't have the symptoms now, but what is the management? So it becomes hard in a 45-year-old or a 50-year-old to look back and make the diagnosis. And the reason for that is as the woman with PCOS gets older, her periods will become regular. This is not often shared or discussed with a patient, so they are not aware that some of the symptoms of PCOS actually get better with age. So in the 40s, it's hard for me to make a diagnosis because now my patient has regular periods every month. And if I was to draw her testosterone levels, those would also be in the normal range because those levels start dropping with age. And one then has to base the diagnoses on what the history that the patient is giving you. And they may not recollect it in detail, or if they have records from earlier on, that could be useful. But those are the two challenging time points when one has to be careful of not overcalling this syndrome and making sure that the diagnosis is correct.
Thank you, doctor, for explaining that. So I believe Penn is conducting the COMET-PCOS study, and it'd be great if you could talk about what the trial is about and what you're planning to achieve through it.
Yeah, thank you for giving us this opportunity to discuss. This is a really important study that is funded by the National Institute of Health in the U.S. It's called COMET-PCOS, so COMET-PCOS. And we'll come a little bit, I think, later in your podcast to talk about the treatments for PCOS. But briefly, like the first line of treatment is a birth control pill. And the reason being that they make the periods regular, as well as they drop the male hormone levels, and hence, one treatment helps with both symptoms of PCOS. However, we and other researchers have shown that birth control pills may not be the suitable first line for all patients. So, for example, women who have a weight issue, women who might be overweight or obese, birth control pills could increase the blood pressure. They could make their cholesterol levels abnormal, and there could be side effects that are not desirable. So another treatment of choice is metformin, and you heard Peggy talk about that. So
yes.
The reason metformin can be a good treatment is because it helps with weight management. Even though it's not a weight loss medication, it helps a number of patients manage their weight better. It also helps, as you heard Dr. Amaro talk about insulin resistance, so it improves the insulin sensitivity, and hence the cholesterol numbers might look better in these patients. The glucose or the sugar levels might be better. So the question then is, in our patients who have higher risk, like the ones who are overweight and obese, and unfortunately a number of women with PCOS do struggle with weight, what is the real treatment? Which medication should we give them? And believe it or not, we really did not have an answer to this question. And that is why we got funded to do this study, where one group of women will get the birth control, one group of women will get metformin, and one group will get both. And the question we are trying to ask is, what is the first line of treatment when a patient is not trying to get pregnant but is just interested in their general health? And what do these medications do to blood pressure, cholesterol, body fat? So we do these neat studies where we look at where the fat is distributed. Is it in the middle of the body or all over? And what will happen by the end of treatment to the fat distribution? So we're excited because we're going to get a lot of information to help guide us as to the first-line treatment in overweight and obese women with PCOS.
Thank you, Dr. Docris. So we can hear from Peggy as well. Peggy was part of the trial. I think she completed it in September 2018, Peggy?
Yes, that's correct.
Yes. So please tell us, how are you feeling now?
Now that I've completed the study, I'm actually feeling quite a bit better. I definitely feel empowered having been part of it, because I feel as though I have this real grasp of where my numbers are, how my body responds to certain interventions. The trial involves me taking 2 medications each night. One was most likely a placebo, and the other was a true medication, but I didn't know which was which. So I was told that I'm either taking birth control, metformin, or both. But because I don't know, I need to take both every night. And so I was randomized into one of those groups. And then every 2 to 4 weeks, I would follow up with a research coordinator. And since being a part of that study, I've actually lost a significant amount of weight. I'm feeling more in power of the PCOS and kind of figuring out a game plan going forward.
Great to hear, Peggy. Why I'm going to ask you this question is because we've got a couple of questions on fatigue being a part of PCOS. So I'd like to know how active you are feeling physically in terms of doing your normal activities during the trial, during the part of the trial. Did you feel an increase in your energy levels, or was there a decrease? I'd like to know this because we've got a couple of questions asking about fatigue and PCOS.
Oh, absolutely. So I actually always thought, growing up and in my early 20s through college, I thought that being excessively fatigued and exhausted was just my baseline. I really just thought that's how I operated, no matter how much sleep I got. It always felt like I was running on snooze. And, I'm an ICU nurse, so that's not the best feeling to have. But on the metformin that I think I was on, I don't know for sure, but just my guess, that brought my energy level up to what I imagine a normal person's energy level was. I was able to sleep through the night I woke up. I didn't need coffee. I didn't feel excessively tired. I was able to get through the day without, caffeine or energy drinks. I really saw like a significant improvement in my energy level as my numbers trended towards normal.
Thank you so much, Peggy, for sharing that. So, as of now, you don't have any PCOS symptoms, or have they been considerably reduced? What do you think?
My periods are definitely more regulated now that I'm on a third-generation birth control, which is what me and my reproductive endocrinologist decided was the best option for me at this point in my life. So my periods are normal. My acne is subsiding. My lab values are looking better. I still think that some of the symptoms of PCOS persist. It is harder to lose weight. I definitely have the skin that I did when I was younger, but I definitely see things going in the right direction, and I don't know that they would have been had I not participated in the trial and really gotten some information.
Thank you very much, Peggy, for joining us and sharing this experience with us. I'm sure many of our listeners would have really loved to hear from you. So moving on, Dr. Amaro and Dr. Allison, questions both of you. PCOS signs and symptoms, as we just heard from Peggy and from Dr. Okras, are typically a little bit more severe if you're obese and can lead to complications. So how do you both go about treating a patient who's overweight and has PCOS? We'll start with Dr. Amaro, and then Dr. Allison, you can jump in with your comments.
Sure, thank you. I am extremely happy to hear about Peggy's experience with metformin, because in the world of metabolism, we do consider metformin as a first-line therapy to not only manage weight, but mostly to improve insulin sensitivity. And improvement in insulin sensitivity helps women manage their weight, but it also helps with carbohydrate metabolism. There are some small pilot studies in the past that also suggested that improving insulin resistance with metformin helped seeing decrease in the male hormones as well. So we do try to use metformin as a first line. But not everybody can tolerate metformin. Not everybody can take metformin. So we're fortunate now that we have other medications to help people, other medications to offer to women with excessive weight. In the last decade, FDA has approved 5 medications for non-surgical weight management. Women with PCOS typically were not excluded from the studies. Even though the studies were not specifically designed for women with PCOS were part of the studies of those medications. So we feel quite comfortable prescribing some of them and monitoring women closely. So there are medications that we believe are not simply appetite suppressants, because it's not just the appetite that drives the weight up. It's the whole hormonal imbalance that leads to difficulty losing weight, even when women introduce healthier lifestyle. So with the help of medications, what we're seeing that set point for the weight is brought down, so it is easier to achieve weight loss with proper diet and exercise. So that's what we do in Penn Metabolic Medicine when we see our mutual patients there. We prescribe weight loss medication, provide dietary counseling, and monitor patients for side effects and interactions with other medications.
Dr. Allison, would you like to add something more to what Dr. Amaro was just explaining?
Sure. So weight management, as Peggy was saying, and as some of the questions coming in were indicating, can be it's very frustrating, I think, in general, because our food environment is very challenging. There's all kinds of sights and smells of food everywhere we go, it seems. So that's just challenging for the general population. And then with PCOS, you're layering on these extra complications of the hormones that may drive up one's weight and make it more challenging, as Peggy was describing it, as like almost weight resistant, really a little bit tougher to lose weight. We see this in patients with diabetes sometimes too. So we generally, in our behavioral treatments, we generally do the same type of treatment. We do what we know works and can apply it to women with patients who have PCOS. And that would be the best predictor of weight loss is monitoring one's intake. And I know it's a pain to do. It certainly is, but it really is effective in really trying to figure out how much you're eating and paying attention, if you are paying attention to calories and other macronutrients such as carbohydrates and protein, it will give you the best information. It's not perfect, but it certainly gives you more information to work on. If you are seeing a counselor to manage your weight, or if you're just doing it on your own, it's going to give you much more information to say this is working, this isn't. Now, I know that sometimes people can become very obsessed with monitoring what they're eating, and sometimes this can lead to disordered eating types of behaviors. And again, that would be something we would watch out for. We would want to work with the patient and say, if you're becoming too obsessed with this monitoring and it's leading to unhealthy eating and compensatory behaviors, then we would change that approach and say, nope, you can't monitor. It's, how can we help with some other tools like cognitive behavioral therapy to help you be able to manage your anxiety about the weight, help you have some weight acceptance, and adapt healthy behaviors without focusing so much on the number on the scale, which also can be helpful in managing symptoms. So it really can be an individual approach. Some people can do standardized weight management programs and do quite fine, but other folks who maybe have more complex symptoms with depression, anxiety, or disordered eating really need a more nuanced approach, which then we would suggest something like a cognitive behavioral therapy to address all of that more comprehensively, because eating doesn't happen in isolation. It can be influenced by mood, by the environment, by lots of different factors, and we wouldn't want to neglect those in somebody who's struggling to manage their weight.
Absolutely. Very on the discussing weight management, Dr. Amaro, is bariatric weight loss surgery effective at lowering the weight of women with PCOS, and does it improve their symptoms at all?
Very good question. Just recently, Cleveland Clinic published a review of cases when women with PCOS have undergone bariatric surgery. So they described, I believe, over 40 women with PCOS had bariatric surgery in the 5-year period, observation period time that they were reporting. And women with PCOS lost on average 20% of their weight after bariatric surgery, and their hormonal profiles did improve. Male hormones came down, insulin resistance improved, and cholesterol profile, more specifically triglycerides and good cholesterol, have changed in a favorable way. Again, bariatric weight loss studies were not designed specifically for women with PCOS, but women with PCOS did undergo bariatric surgery, and their data were analyzed.
So we have a question from the audience. So they want to know how much weight you actually need to lose in order to improve your symptoms, or even to increase your fertility.
Very good and very important question. From multiple studies in different conditions, including PCOS, we know that the benefit of weight loss usually begins around 5%. So between 5 and 10% of weight loss usually results in some metabolic improvements. It could be improvements in ovulation or ovarian function. It could be improvement in insulin sensitivity and glucose metabolism. It could be improvement in blood pressure, and people can go off medication. So between 5 and 10% is usually the weight loss we target in the first 6 to 12 months when we work with the patients. Anything extra is excellent, but even if women achieve just 5 to 10%, that is already clinically significant.
Great. So I just have a couple of more questions before I hand over to Valerie for her to bring in the patient perspective. Dr. Allison, I was reading up, doing a little bit of research for this show. I came upon a couple of papers, most of them discussing mental distress, and I know you did touch upon low self-esteem and depression. So we have a question from our audience who wants to know, can you talk about the link between PCOS and depression?
Sure. So we do, as I mentioned, see increased risk of depression with this, and there are different pathways to it. And often when I see somebody in therapy who has PCOS, the things that we would focus on would be increasing self-esteem, dealing with the symptoms, and so some of that will be acceptance, some of that will be collaborating with Dr. Amaro and Dr. Docris for hair removal services and appropriate treatments to help kind of comprehensively manage the symptoms. But on the psychological side, we would really try to use techniques such as what we call cognitive restructuring, so really trying to understand how a woman thinks about herself and her body and the world, as well as just dealing with the burden of depressive symptoms, which can make you feel fatigued on top of the fatigue you may already feel with PCOS. It may make you feel less engaged from others, not feel like you want to go out and do things, spend time with your friends or family. And so we really try to understand the thought processes that people have, their emotions that they're experiencing, and how those thoughts and emotions end up influencing whether or not they go out, right, or whether or not they engage with others, or maybe if they eat in response to their stressors because that's comforting to them. And then we try to figure out ways, collaboratively for patients to deal with those thoughts in a different way so they have more positive outcomes, such as pushing themselves to go out and having a new experience, which then actually will activate their mood and make them feel better. So we really try to meet the patient where they are, if they are having these symptoms, and engage them with some of these techniques so that they can have more positive ways of handling their stress and dealing with the thoughts that are generated that lead to the depression.
Thank you, Dr. Allison. Dr. Docris, so how much does genes play a role in PCOS?
So this is a really good question. Researchers have been trying to identify genes that might be abnormal in PCOS to try and find that link. And there are a number of large studies, both in the white Caucasian population in America and in Europe, as well as in the Chinese population. And PCOS is a little bit like diabetes, where there's not going to be just one gene that's abnormal, but a number of areas that we call them our hits or targets that might be responsible for the syndrome. So we do believe that genes play a role. It's very often when I see patients, they'll say their mother has similar symptoms, or their sister or a cousin might have similar symptoms. And as we described, PCOS is not just one type. It's varied. There can be different symptoms, and that's why a relative may not have all the symptoms, but just part of it. But we do believe that it is genetically controlled or modulated. In addition to the gene, though, the environment, like you have heard, plays a role. So as the weight goes up, the severity will change, and as you heard, even more encouragingly, as the weight comes down, a lot of the symptoms get better. So we know clearly from the bariatric surgery literature that as the weight comes down, the periods do become regular and the male hormone levels drop, such that a number of the symptoms go away. Nowadays, our patients might ask the question, is PCOS becoming more common? But what we think is that as the weight has gone up for our society in general, periods do become slightly more irregular. The free testosterone levels come up, and so it seems there's a perception that PCOS is more common, but this is the environment in addition to the genes influencing the symptoms of PCOS.